Hi everyone, this is Professor Nicholson lecturing on fluid and electrolyte balance. Please review the following subcompetencies on your own. Body fluid. The pituitary gland secretes antidiuretic hormone to maintain fluid balance. Water is the primary body fluid. Water content varies with age, sex, and adipose tissue. Water contains solutes, such as electrolytes and non-electrolytes. The goal of body fluid is to maintain volume, regulate body temperature, transport nutrients, electrolytes, oxygen throughout the body. It acts as a medium for cellular metabolism, and it assists with digestion and excretion. Body fluid compartments. The biggest difference between intra and extracellular fluids is the concentration of electrolytes. You need to know that. Intracellular fluid is contained within the cells. It's essential for cell function and metabolism. It accounts for approximately 40% of body weight. Then you have extracellular fluid. This is outside the cells. It carries water, electrolytes, nutrients, and oxygen to the cells and removes the waste products of cellular metabolism. Extracellular fluid accounts for 20% of body weight. It exists in three main locations in the body. First, we'll talk about interstitial fluid. This lies in the spaces between the body's cells. Excess fluid within the interstitial space is called edema. Then you have intravascular fluid. This is the plasma within the blood. Its main function is to transport blood cells. Then you have transcellular fluid. This includes specialized fluids such as cerebrospinal, pleural, peritoneal, and synovial fluids, as well as digestive juices. Then we're going to talk about something called third spacing. This is when certain conditions cause fluid to move into an area that makes it physiologically unavailable, such as in the peritoneal space, so ascites for instance. Another example is the pericardial space with pericardial effusion, or into the vesicles, such as those blisters with a burned wound. Those are just some examples. Third spacing is a type of fluid that is literally trapped in a third compartment. It's not within interstitial cells or the intravascular spaces. Movement of fluids and electrolytes. Most of this should be review. Osmosis involves movement of water or other pure solute across a membrane from an area of a less concentrated solution to an area of a more concentrated solution. Water moves across the membrane to dilute the higher concentration of solutes. Recall that a solute is a substance dissolved in body fluid. Solutes may be crystalloids or colloids. Then you have diffusion. This is a passive process by which molecules of a solute move through a cell membrane from an area of higher concentration to an area of lower concentration. Movement occurs until the concentrations are equivalent on both sides of the membrane. Then you have filtration. This is the movement of both water and smaller particles from an area of high pressure to one of low pressure. Hydrostatic pressure is the force created by fluid within a closed system. It is responsible for normal circulation of blood. In other words, blood flows from the high-pressure arterial system to the lower-pressure capillaries and veins. Lastly, you have active transport. This occurs when molecules, such as electrolytes, move across cell membranes from an area of low concentration to an area of high concentration. Active transport requires energy expenditure for the movement to occur against a concentration gradient. Adenosine triphosphate, so ATP, is released from the cell to enable certain substances to acquire the energy needed to pass through the cell membranes. Fluid intake is primarily through drinking fluids. The recommendation is 2,700 milliliters a day for women and 3,700 milliliters a day for men. 20% of fluid intake is from food/metabolism of food. Fluid intake is regulated by thirst, so that change in plasma osmolality as well as via the hypothalamus within the brain. These are typical fluid outputs from the body. For urine, there needs to be at least 35 to 70 milliliters an hour for adults to have adequate output. That's equivalent to that 1,500 milliliters per day you see here. With the skin, this is sensible, so perceived fluid loss through the skin that occurs through perspiration, at least 300 to 600 milliliters a day. Perspiration varies based on temperature, skeletal muscle activity, and metabolic activity. Fever, exercise, and some disease processes increase metabolic activity and heat production, leading to increased fluid loss. Regarding the lungs, about 300 milliliters per day of output comes from the lungs. This is insensible loss that occurs through the lungs as water is exhaled with the breath. An increase in respiratory rate increases the amount of fluid lost. Regarding feces, this is about 100 to 200 milliliters of output a day. Soft stools contain more water than hard stools. As stool frequency increases, water loss also increases. Hormonal regulation. Antidiuretic hormone, so ADH, is pressure sensors in the vascular system that stimulate or inhibit the release of antidiuretic hormone from the pituitary gland. ADH causes the kidneys to retain fluid. If fluid volume within the vascular system is low, fluid pressures within the system decrease, and more ADH is released. If fluid volume and therefore pressure increases, less ADH is released and the kidneys eliminate more fluid. ADH is also produced in response to a rise in serum osmolality, fever, pain, stress, and some opioids. Regarding the renin-angiotensin system, so the RAAS system, this is when extracellular, for example, intravascular fluid volume is decreased. Receptors in the glomeruli respond to the decreased perfusion of the kidneys by releasing renin. Renin is an enzyme responsible for the chain of reactions that converts angiotensinogen to angiotensin II. Angiotensin II acts on the nephrons to retain sodium and water and directs the adrenal cortex to release aldosterone. Aldosterone, continuing on, stimulates the distal tubules of the kidneys to reabsorb sodium and excrete potassium. Sodium reabsorption results in passive reabsorption of water, thereby increasing the plasma volume and improving kidney perfusion. When fluid excess is present, renin is not released, and this process stops. Next, you have the thyroid hormone. This affects fluid volume by influencing cardiac output. An increase in thyroid hormone causes an increase in cardiac output, thereby increasing glomerular filtration rate and urine output. A decrease has the opposite effect. Lastly, we have the natriuresis brain natriuretic peptide, so the BNP. This is the discharge of sodium through urine. BNP can be measured in the serum to help determine presence of heart failure with fluid excess and to distinguish heart failure from pulmonary edema. Electrolytes are substances that carry an electrical charge. It's measured in milliequivalents or milligrams. For intracellular fluid, these are the major electrolytes. You have potassium, magnesium, and phosphate. For extracellular fluid, the major electrolytes include sodium and chloride. It is important to understand the major electrolytes and their function within the body. I know this lecture gets a little heavy, so please stay with me and take a break when you need to. Sodium is a major cation in the extracellular fluid. Its primary function is to regulate fluid volume. When sodium is reabsorbed in the kidney, water and potassium are also reabsorbed, thereby maintaining extracellular fluid volume. Adults should limit intake of salt to 2,300 milligrams per day. For older adults, African Americans, who are statistically more at risk, and persons with chronic diseases, for example those with hypertension and kidney disease, the amount should be limited to about 1,500 milligrams per day. This is all per the Department of Health and Human Services. Regarding potassium, this is the major cation of the intracellular fluid. Only 2% of body potassium is found in the extracellular fluid. Potassium is a key electrolyte in cellular metabolism. According to the Dietary Guidelines for Americans, at least 4,700 milligrams a day of potassium is recommended. However, most American women ages 31 to 50 years consume less than half the recommended amount of potassium, and intake is only moderately higher for men. Major electrolytes continued. We'll start with calcium. This is responsible for bone health and neuromuscular and cardiac function. It is also an essential factor in blood clotting. About 99% of body calcium is located in the bones and teeth. The remaining 1% circulates in the blood and affects system functions. As serum levels drop, calcium leaches from the bones into the blood to compensate. If dietary intake is not sufficient to replace it, bone loss occurs. Prolonged deficiencies lead to osteoporosis. Next, you have magnesium. It is a mineral used in more than 300 biochemical reactions in the body. Like calcium, only about 1% of magnesium is found in the blood. The remaining 99% is divided between the intracellular fluid and bone, also in combination with calcium and phosphorus. Although magnesium deficiency is rare, you may find low levels in individuals who have high alcohol intake. Some malabsorption disorders may also cause magnesium depletion. Next, you have chloride. It is the most abundant anion in the extracellular fluid. It is usually bound with other ions, especially sodium or potassium, for example, as sodium chloride or salt. A healthy adult between the ages of 19 and 50 should consume 2.3 grams of chloride each day, along with 1.5 grams of sodium to replace daily losses and maintain serum blood levels, per the National Academies of Science. Major electrolytes continued. We'll start with phosphate. Most phosphorus in the body is combined with oxygen, hence forming phosphate. This is mostly bound with calcium in teeth and bones as calcium phosphate. Phosphate is the most abundant intracellular anion. Phosphate and calcium exist in an inverse relationship. Next, we have bicarbonate. This is present in both intracellular fluid and extracellular fluid. The kidneys regulate extracellular bicarbonate to maintain an acid-base balance. When serum levels rise, the kidneys excrete excess bicarbonate. If serum levels are low, the kidneys conserve the bicarbonate. Fluid imbalances. First, we're going to talk about deficit in fluid volume. First, we have hypovolemia. This occurs when there is proportional loss of fluid and electrolytes from the extracellular fluid. Loss of blood volume is called hypovolemia. Next, we have dehydration. This is described as a state of negative fluid balance in which there is a loss of water. Remember, hydro equals water. This loss of water is from the intracellular, extracellular, or intravascular spaces. Next, we have weight loss. Weight loss of a sudden 5% loss of body weight is considered clinically significant. When loss approaches 8%, fluid loss is severe. A sudden loss of 15% of body weight due to fluid loss is usually fatal. A patient with fluid volume deficit usually has elevated blood urea nitrogen, so that BUN, to creatinine ratio, and elevated hematocrits as well. Both values increase because there is less water in proportion to the solid substances being measured. Fluid imbalances continued. Next, we're going to talk about fluid volume excess. Hypervolemia involves excessive retention of sodium and water in the extracellular fluid. Fluid volume excess can result from excessive salt intake, disease affecting kidney or liver function, or poor pumping action of the heart. The retained sodium increases osmotic pressure in the extracellular fluid. This pressure pulls from the cells into the extracellular fluid. Signs of fluid overload include the blood pressure being elevated, pulse is bounding, and respirations are increased and shallow. The neck veins may become distended, along with increased intravascular volume. Excess extracellular fluid may accumulate in the tissues, especially in dependent areas, as edema. The skin is pale and cool. Urine output becomes dilute and volume increases. The patient rapidly gains weight. In severe fluid overload, the patient develops moist crackles in the lungs, dyspnea, and ascites, so that excess peritoneal fluid. Hemodilution causes BUN, hematocrit, and the specific gravity of the urine to decrease. Signs and symptoms of fluid volume deficit. Early signs include thirst as well as an increased heart rate. This is due to the constriction of blood vessels. Later signs and symptoms include those of hypovolemic shock, so a rapid/thready pulse, orthostatic hypotension, dry skin and mucous membranes, decreased skin turgor, decreased urine output, noting that this needs to be approximately 35 milliliters per hour. Anything less is super concerning. And another sign and symptom is flat neck veins. Other signs and symptoms include BUN and hematocrit elevation, so this creates more concentrated blood. Urine-specific gravity also increases. Think more concentrated urine. Please also keep in mind that a patient diagnosed with fluid volume deficit should have their temperature monitored for potential elevation. So, an elevated temperature does coincide with a sign of fluid volume deficit. You need to know signs and symptoms of fluid overload. This includes elevated blood pressure, increased shallow respirations, cool, pale skin, distended neck veins, so jugular vein distension, edema, rapid weight gain, and very severe signs and symptoms include moist crackles in the lungs, dyspnea, and ascites. Also, there may be hemodilution of labs, so think less concentrated, so values appear to be low. Possible causes of fluid overload include excess sodium intake, kidney or liver disease, heart failure, as well as too much water intake, for example, excess IV fluids. Pulse check. Which patient is not at risk for fluid volume deficit? The answer here is an 84-year-old patient complaining of shortness of breath after receiving a bolus of D5 normal saline. Why? This patient is experiencing fluid volume excess, or you may hear it termed fluid volume overload. All other options lead to fluid volume deficit. Please review the following lab values. Electrolyte balance requires balancing of intake and output. Disease states can disrupt this balance. Some electrolytes are included on the basic metabolic panel, which is a lab blood draw. These labs include sodium, potassium, chloride, as well as calcium. However, others may need to be ordered separately, such as magnesium and phosphate. Great examples of electrolyte imbalances include vomiting and burns, as these disrupt that balance of intake and output. These are the electrolyte imbalances that we will be discussing now. Sodium. Normal range is 135 to 146 millimoles per liter. It is a major cation in the extracellular fluid. It regulates fluid volume, so where sodium goes, fluid follows. It's reabsorbed or excreted by kidneys in response to hormones. It can be lost in perspiration and feces. Certain medications can promote loss, for example, furosemide. Sources include table salt, preserved foods, processed foods, cured meats, cheese, milk, and bread. Hypernatremia, so sodium greater than 146 millimoles per liter. The cause is too much sodium intake or too little water. Other causes could be, but are not limited to, profuse sweating, heat stroke, diabetes insipidus, as well as over-administration of hypertonic tube feeds or intravascular fluids with sodium chloride. Signs and symptoms include restlessness, confusion, increased thirst, fever, dry mouth, and dry mucous membranes. More severe signs and symptoms include hallucinations, irritability, lethargy, and seizures. Treatment is usually sodium restriction and increase of water intake. It's important to monitor vital signs, intake and output, as well as neurological and mental status. Hyponatremia, so sodium less than 135 millimoles per liter. The cause is sodium loss or excess water. Other factors include, but are not limited to, diuretics, GI fluid loss, adrenal insufficiency, syndrome of inappropriate antidiuretic hormone, as well as excess hypotonic IV fluid administration. Signs and symptoms include anorexia, nausea, vomiting, muscle weakness, lethargy, confusion, and seizures. This is due to the fluid shifts in the brain. Treatment is to increase sodium intake, orally or intravenously. You must infuse IV sodium slowly, very slowly, to prevent quick fluid shifts. Monitoring of vital signs, intake and output, labs, neurochecks, and seizure precautions is critical. Potassium. The normal range is 3.4 to 5.2 millimoles per deciliter. It is the major cation in intracellular fluid. It regulates conduction of heart rhythm. So you need to know that it has a direct effect on cardiac muscle function. It assists with acid-base balance, and it's reabsorbed and excreted largely by the kidneys. It may be lost via vomiting and diarrhea. It has multiple diuretics. Sources include bananas, oranges, figs and dates, carrots, tomatoes, potatoes, leafy greens, dairy, and meat. Hyperkalemia, so potassium greater than 5.2 millimoles per liter. Causes include but are not limited to renal failure, potassium-sparing diuretics, high dietary or supplemental intake, hypoaldosteronism, high potassium intake, especially coupled with renal insufficiency, as well as acidosis and major trauma. Signs and symptoms include muscle weakness, cardiac dysrhythmias, as well as peaked T waves on ECGs. Treatments include combination of IV dextrose, insulin, and PO Electrolyte. The combination actually promotes potassium loss via the GI tract and shifts of potassium ions back into cells and out of the bloodstream. Other treatments include stopping supplements, as well as educating patients on low potassium diets, especially those renal patients. It's also imperative to monitor vital signs, intake and output, as well as renal function tests and other labs. A fun fact, hemolyzed serum sample produces pseudohyperkalemia. This is a falsely elevated serum potassium level caused by potassium leakage from cells during or after blood collection. It's not a true excess of potassium in the body. Hypokalemia, so potassium less than 3.4 millimoles per liter. Causes could be related to, but not limited to, diuretics, steroid administration, hyperaldosteronism, anorexia, bulimia, as well as GI loss such as vomiting, gastric suctioning, and diarrhea. Signs and symptoms include fatigue, skeletal muscle weakness, nausea, vomiting, flattened T waves on ECGs, as well as cardiac arrhythmias. Treatment includes increasing dietary intake, curbing underlying GI issues, or giving PO/IV supplements. Note, IV potassium must never be given IV push, and there are very strict policies on the amount per hour via infusion pumps. You need to know your policy, as this is unit-based. Lastly, monitoring for hypokalemia includes vital signs, of course, intake and output, labs, and cardiac monitoring. Calcium. The normal range is 8.5 to 10.5 milligrams per deciliter. It promotes transmission of nerve impulses, as well as regulates muscle contractions. It's a major component of bone, along with phosphorus. It's regulated by the parathyroid hormone and calcitonin from the thyroid. It does work with vitamin D to maintain calcium balance. Vitamin D also promotes gut absorption as it strengthens the intestinal barrier, which helps the gut absorb nutrients while keeping harmful bacteria out. Back to calcium. Sources include milk products, dark leafy greens, salmon, bread, and cereals. Hypercalcemia, so calcium greater than 10.5 milligrams per deciliter. Causes include, but are not limited to, hyperparathyroidism, bone malignancy, oversupplementation, thiazide diuretics, as well as prolonged immobilization. Signs and symptoms include muscle weakness, constipation, anorexia, nausea, vomiting, kidney stones, that's a big one, altered behavior, as well as bradycardia. Treatments include stopping supplementation, encourage fluid intake to prevent kidney stones, encourage fiber, as well as IV medications to stop bone breakdown. Hypocalcemia, so calcium less than 8.5 milligrams per deciliter. Causes are hypoparathyroidism, malabsorption, as well as low vitamin D. Signs and symptoms include numbness/tingling of extremities, Tetany, a positive swastic sign, which is twitching of facial muscles, as well as a positive troso sign, which is carpopedal spasms from ischemia. For example, pressure applied to the upper arm from a blood pressure cuff. Other signs and symptoms include muscle cramps, diarrhea, cardiac irritability, as well as laryngeal spasm. Treatments include increased dietary and supplemental calcium. This can be PO or IV. Note, as mentioned in the last slide, encourage increased fluid intake to help prevent kidney stones. That's important for education of your patients. Lastly, for monitoring, you want to focus on neuromuscular as well as cardiac function and intake and output. Magnesium. The normal range is 1.6 to 2.6 milligrams per deciliter. It's important for protein and carbohydrate metabolism. It's necessary for various cellular processes and maintaining potassium gradient in cells. It's involved in nerve and muscular electrical activity, including in the heart. It's ingested by diet and excreted by the kidneys. The loss is triggered by diuretics, excess alcohol intake, and poorly controlled diabetes mellitus. Sources are that it's in most foods, but highest in green vegetables, cereal, grains, and nuts. Hypermagnesemia. This is when magnesium is greater than 2.6 milligrams per deciliter. It's caused by renal failure, oversupplementation, especially antacids and laxatives, as well as adrenal insufficiency, among others. Signs and symptoms include flushing, warm skin, hypotension, bradycardia and bradypnea, drowsiness, lethargy, as well as slow reflexes. Treatment is to restrict intake and supplements. Monitoring includes cardiac function, vital signs, of course, reflexes, as well as labs. Hypomagnesemia is when magnesium is less than 1.6 milligrams per deciliter. It's caused by chronic alcoholism, malabsorption, as well as diabetic ketoacidosis, among others. Signs and symptoms include neuromuscular irritability, mood change, as well as dysrhythmias. Treatment includes increased dietary intake, as well as PO or IV supplementation, and stopping alcohol, which is ETOH abbreviated. Monitoring includes cardiac function as well as withdrawal monitoring and labs. Chloride. The normal range is 98 to 110 millimoles per deciliter. It's a major anion of extracellular fluid. It works with sodium to maintain fluid gradients between compartments. It's also essential for production of hydrochloric acid for gastric secretions. It's reabsorbed and excreted by the kidneys along with sodium. An example, chloride is lost with vomit. Sources include high salt foods, and treatment of chloride imbalance occurs indirectly by treatment of sodium imbalances. Phosphate. It's important for intracellular activity and cell division. It promotes nerve and muscle action. It combines with calcium to form mineral salts in bones and teeth. Levels vary inversely with calcium. It's regulated by the parathyroid hormone. Sources include meat, fish, poultry, milk products, legumes, as well as carbonated beverages. Please don't confuse this with alkaline phosphatase, which is ALP. They are distinct but not related entities. ALP is an enzyme that breaks down phosphate esters, while phosphate is a mineral crucial for various bodily functions. I do not expect you to know this lab value for this content. Acid-base imbalances are the balance of acid and base in the body. Kind of like a tug of war, the body loves to keep pH in balance. An acid is a compound that contains hydrogen ions, and a base is a compound that accepts the hydrogen ions. The acceptable range for pH is 7.35 to 7.45. It is measured by arterial blood gases. How acid-base regulation works. Buffer systems prevent wide swings in pH. A buffer system consists of a weak acid and a weak base. Buffer molecules keep strong acids or bases from altering the pH, either by absorbing or releasing free hydrogen ions. Regarding respiratory mechanisms, the lungs are the second line of defense to restore normal pH. They control the body's carbonic acid supply via carbon dioxide retention or removal. When the serum pH is too acidic, so the pH is low, the lungs remove carbon dioxide through rapid, deep breathing. This reduces the amount of carbon dioxide available to make carbonic acid. On the other hand, if the serum pH is too alkaline, so the pH is high, the lungs try to conserve carbon dioxide through shallow respirations. This system works with the carbonic acid sodium bicarbonate buffer system to maintain the 20:1 ratio of base to acid. Lastly, renal mechanisms. The last line of defense is the kidneys, which regulate the concentration of plasma bicarbonate. They can neutralize more acid or base than either the respiratory system or the chemical buffers. If the serum pH is too acidic, the kidneys conserve additional bicarbonate to neutralize the acid. If the serum pH is too alkaline, the kidneys excrete additional bicarbonate to lower the amount of base and thereby decrease the pH. The kidneys also buffer pH by forming acids and ammonium, which is a base. Although the renal system is very effective at altering pH, it is slow. It may take up to 3 days to return the pH to normal limits. This process is known as compensation. The pH returns to normal, but the carbon dioxide or bicarbonate level is abnormal. Acid-base imbalances. Acidosis is when there's too much acid in body fluids. The serum pH is below 7.35. There are too many hydrogen ions or too little bicarbonate. The respiratory cause is retention of carbon dioxide. The metabolic cause is loss of bicarbonate. On the other hand, we have alkalosis. This is an excess base in the body. The serum pH is above 7.45. There's too few hydrogen ions or too much bicarbonate, so opposite of acidosis. The respiratory cause is blowing off carbon dioxide, and the metabolic cause is an increase in bicarbonate. I am not testing you on these mnemonics, but it is good to start gaining an understanding of what patients experience when there is an acid-base imbalance. Components of ABG monitoring. Arterial pH range is 7.35 to 7.45. Partial carbon dioxide is 35 to 45 mercury units. This is partial pressure of carbon dioxide, like I just said. It reflects the concentration of dissolved carbon dioxide. And then you have the bicarbonate. It's 22 to 26 milliequivalents per liter. The body uses bicarbonate to regulate pH, preventing it from becoming too acidic. Indication of renal function and ability to excrete or reabsorb base as needed. Please just understand the basics of ABG interpretation for now, such as what is on this slide. Compensated and uncompensated will be discussed later in the nursing program. I created this table as a supplement to your learning. I also have additional supplements within the Blackboard module, not requirements, but just techniques that may help you with basic ABG interpretation. Here I have the Rome method. This is how I personally interpret my ABGs best. Everybody's a little bit different. Rome means respiratory opposite, so your arrows are going to be opposite, and metabolic equal, so your arrows would be equal. So what do I mean by that? Let's look at the first row together. We always look at pH first because that's going to determine if the situation is acidotic or alkaline. Our pH value is low in this scenario. We're next going to look at partial carbon dioxide. In this scenario, it is elevated. Lastly, we're going to look at your bicarb. It is within range. Please note that with basic ABG interpretation, it's only going to have these three values within the question that I give you. I am not going to be asking you about compensated versus uncompensated within this course. You are going to learn that later in your nursing program, as mentioned. So to finalize this scenario, because the direction of your arrows are opposite, we are going to have respiratory acidosis. And remember, we know it's acidotic because the pH is what determines if it's acidotic or alkaline. To look at one more scenario, we have a pH that's low in this row here. Our partial carbon dioxide is within normal limits, and our bicarb is low. Because the direction of your arrows are equal, we are going to have metabolic acidosis. And remember, we know it's acidotic because the pH is low. Pulse check. Please take a moment to pause this video and interpret this ABG. Hopefully by now you already paused and are here for the answer. Here your pH is 7.32. We know this is out of range because it is low. Remember, the range is 7.35 to 7.45. We know automatically now that this scenario is going to be an acidotic situation. Now we're going to look at partial carbon dioxide. Here it is 58. We know it is high because remember, our range is 35 to 45. Now we're going to look at our bicarb. We know it is within range because remember, in range is 22 to 26 and here it is 24. So, because our issue is with the partial bicarb, and we know that it is an acidotic situation, our arrows are opposite directions. So therefore, we have respiratory acidosis. Nursing assessment of fluid, electrolyte, and acid-base imbalances. For a head-to-toe physical assessment, it's important to start with an exam of the integumentary system when focusing on a patient's fluid balance. You're also going to assess their vital signs, daily weights, and fluid intake and output. You need to know that a healthy adult intake and output is about the same. It's not always equal, but it's about the same. Regarding lab studies, you need to note that serum lab values are the most accurate when determining fluid and electrolyte imbalances. So a serum lab value is the most accurate when determining if there is a fluid and electrolyte imbalance. The following are nursing diagnoses directly related to fluid balance as well as electrolyte and acid-base imbalances. I did not provide the related to portion of these diagnoses as this can vary with each patient scenario. Nursing interventions. First, we have dietary teaching. This is to promote fluid and electrolyte balance. Most people need to limit their sodium intake, for instance, and increase their dietary potassium and calcium. As previously discussed, most people in the United States consume more sodium than they should and not enough potassium and calcium. You should teach clients to eat foods rich in potassium and calcium every day and to avoid sodium-rich foods. For example, nurses should instruct clients to read food labels, particularly when trying to limit sodium intake. Oral electrolyte supplements is another intervention. Encourage patients to take potassium supplements with juice to mask the taste. You should also teach patients to take supplements as prescribed to maintain electrolyte balance. You should remind patients that supplements are medications and should be viewed as part of the treatment plan. If the patient's medications are altered, these should be reviewed, and the need for supplementation should also be reviewed. It's important to also caution patients with salt substitutes that contain potassium. If the patient has been advised to use salt substitutes, this should be reviewed, as well as the need for potassium supplements. Regarding parenteral replacement of fluids and/or electrolytes, when fluid loss is severe or the patient cannot tolerate oral or tube feedings, fluid volume is replaced parenterally. IV therapy is the administration of fluids, electrolytes, medications, or nutrients by the venous route. Nursing interventions continued. Nurses should administer prescribed IV fluids based on the patient's condition. This should be review. Isotonic solutions remain inside the blood vessels. As a result, they are useful for patients with hypotension or hypovolemia. Patients at risk for fluid volume excess must be closely monitored when they receive isotonic fluid replacement because they may easily develop fluid overload. The osmolality of a hypotonic solution is less than that of serum. Therefore, when infused, these solutions pull body water from the intravascular compartment into the interstitial fluid compartment. Hypotonic fluid is used to correct cellular dehydration. Never give hypotonic solutions to patients at risk for increased intracerebral pressure because they can cause or exacerbate cerebral edema. The osmolality of hypertonic fluids is higher than that of serum. When administered, they pull fluids and electrolytes from the intracellular and interstitial compartments into the intravascular compartment. Hypertonic fluids can stabilize blood pressure, increase urine output, and reduce edema.